spend a little bit of time talking about colon wound management. It's really kind of interesting if you're into that sort of thing, which I kind of like colons. They are your friends, and unless you happen to get shot in them, then it's a problem. But I have no conflicts, and yes, the place that I work really is called the Elvis Presley Memorial Trauma Center. And as an interesting tidbit, and this perhaps could win you an adult beverage in a contest or something, it remains the only freestanding building in the world named in honor of the King. So there you have it, Elvis Presley Memorial Trauma Center. Colon wounds have been written about for really quite some time, and the first record of a colon wound was from the book of Judges in the Old Testament. And it was described as the hilt also went in after the blade, and the fat closed upon the blade, for he drew out the sword, and the dirt came out. Okay, kind of a messy injury. And it was interesting that Ehud would stab the king. And if you'll note on this on the image, he's stabbing him with his left hand. Because you think, how the heck does a guy get in to see the king when he's armed? Well, most warriors were right-handed, so when they would come in to see some dignitary or whatnot, they would feel their left hip, because if they were right-handed, they would reach with their right hand to their left hip, pull out their knife, and stab whoever needed to be stabbed. But in this case, this guy was left-handed, so his knife was over on the right side. So needless to say, I would imagine that I guess it's sort of like some guy running into the White House. I'm sure somebody lost their job over this one. But at any rate, really, there wasn't very much written about colon injuries, really, since that initial description in the book of Judges until about the Civil War, where penetrating colon wounds were predominantly managed non-operatively. That's primarily because there weren't a whole lot of laparotomies done during the Civil War, because anesthesia was lousy and conditions were lousy. And being from the South, we like to call that the War of Northern Aggression. But nonetheless, there were incredibly high mortality rates, as you would expect. But even those patients who did get operated on, their mortality really didn't change all that much. So most wartime injuries, at least during the Civil War, were managed non-operatively. The biggest operations that they did during that time, of course, were amputations. In World War I, the weaponry improved dramatically, so there were a lot more destructive injuries, but still the mortality rate was lousy, even though there was a little bit better overall care and anesthesia was available. Still, patients who were shot in the abdomen and had colon injuries still had excessively high mortalities of up to 75% or so. And it really wasn't until World War II came about that the mortality rate dropped, thanks to thanks to several things. One is penicillin. Penicillin really changed the whole course of sepsis following penetrating injuries. It also saved a lot of other things penicillin was good for. Sorry. But the mortality rate following, these are probably from other soldiers, I think. Mortality rate dropped to about a quarter, really, about 25% or so following colon injury, and that's pretty dramatic. Well, there's a number of things. There was advancements in triage, so people didn't lay out in the field, with having internal bowel movements and bleeding all at the same time. Those patients got more aggressively resuscitated. We had antibiotics. There were sulfa powder and penicillin, and then we were also able to transfuse these wounded soldiers. So the mortality rate dropped dramatically. There was also an edict that was put out that mandated exteriorization of all colon injuries. And in fact, Major General W.H. Ogilvie, who was in charge of the European theater, wrote about this and in fact said, simple closure of the wound of the colon, however small, is unwarranted. Men have survived such an operation, but others have died who would still be alive had they fallen into the hands of a surgeon with less optimism and more sense. Pretty aggressive there, Mage, but nonetheless, he mandated that in the European theater that all patients with colon injuries, regardless of how trivial the wound happened to be, all those patients got colostomies. Well, the proof of the pudding's in the taste. Mortality rate dropped dramatically. He went on to further say that perhaps this is the greatest single factor in the improved results that they were able to record. Well, I'm sure that had a fair amount to do with it, in addition to all the other things that we mentioned, not the least of which was antibiotics. But it went so far that if you primarily repaired a colon wound, then that surgeon would undergo court-martial, or it would certainly be grounds for court-martial. Pretty serious about doing colostomies in those patients. Well, the group from New Orleans, after the war, this paper came out in 1952, which is pretty interesting, at a charity hospital in New Orleans. And they were really, the Woodall and Oxford were the first to really kind of describe the differences between wartime injuries and civilian injuries. And back then, civilian injuries were predominantly handgun injuries, little 22s or 25s, low-velocity missiles, not a lot of big destructive wounds, and therefore they advocated that you could probably primarily repair some of these wounds, and not everyone needs a colostomy. Again, this is 1952. Again, kind of a dearth of publication since then, until this was a pretty landmark article that was written by Harlan Stone and Tim Fabian. And this was published in 1979 in the Annals, where patients were randomized between primary repair and colostomy. And there were certain criteria for obligatory colostomy. And what they did was they took the patients who were the most severely injured, and those patients all got colostomies. That's pretty reasonable. Take very high-risk patients, and so these are all patients who would otherwise be amenable to primary repair, and they would undergo they would be randomized to either primary repair or colostomy. And what they found was that there was a dramatic decrease in infectious morbidity in patients who underwent primary repair than those patients who underwent colostomy. Well, that sort of added a new wrinkle to taking care of these patients. And from that data, they concluded that the safety of primary repair is present. I mean, it's safe to primarily repair certain colon wounds. But how do you define a high-risk patient? They had their criteria for obligatory colostomy. Well, the truth is a lot of those wounds you probably could have repaired primarily, but again, they erred on the side of caution. So when Dr. Fabian left Atlanta, left Emory, or Grady at the time, and came to Memphis, he started a prospective trial where we took all patients. This happened back when I was a resident. We took all patients who had colon wounds and primarily repaired them. Had 102 consecutive patients with penetrating colon injuries, and it didn't really matter what they had. They all underwent primary repair or resection and anastomosis, I mean, if it was a destructive wound. So of the 83 patients who had primary repair, there were no leaks. 12 people had resection and anastomosis. One of those was mine as a resident. Not the leak. Okay, maybe it was me that had the leak. But, yeah. And then 7 patients had ankylostomies. And what we defined in this particular study was that the risk factors were if a patient received more than 4 units of blood, if they had significant contamination or an increased colon injury score. And at the time, colon injury score was kind of a popular thing. It was just a measure of how bad the organ itself was hurt. 1 being hurt not very badly, 5 being mashed all to pieces. So bad injuries, lots of transfusions, that equals intra-abdominal abscess. And basically from this data concluded that nearly all penetrating injuries can be repaired either primarily or with resection and anastomosis. Well, what about this resection and anastomosis? That's kind of a difficult thing, especially in a patient who's particularly ill. Chapuis, again, from Louisiana, said that primary repair or resection and anastomosis should be considered for the treatment of all patients. All patients. That's pretty inclusive, right? There's not a lot of wiggle room there when you put all in there, okay? And the generalization, however, from their data, from the data in this particular report, was made on 11 patients who had resection and anastomosis. Well, I'm not a math major, but 11 is not really a very large number, and certainly not a number that's large enough to include the word all in the description. So when is it appropriate to do resection and anastomosis? For example, this Here's a patient who has really not that bad. It's a bit of a destructive wound, a little bit of internal bowel movements, but not a huge amount. So should this patient undergo resection and anastomosis or ostomy? Well, we decided to try to take a look at that. So we defined destructive colon injuries as wounds that involve greater than 50% of the wound of the colon wall circumference, or a colon that was completely transected, completely shot in two, or if there was an injury to the wound plus an associated mesenteric injury, which then rendered that segment of colon completely devascularized. And no matter what you do to that, you know that it's going to do poorly if you leave it in, so you have to resect it. So Ronnie Stewart, who is now the current chairman of the Committee on Trauma and chairman in San Antonio, when he did his fellowship in Memphis, looked at 60 patients who had destructive colon injuries, and basically in looking at these patients and looking at those patients who did well and who didn't, we found that if they had a destructive colon injury, again, that's everybody in this study had a destructive colon injury, but if they had other significant comorbidities, or if they got greater than 6 units of blood, 42% of those suture lines failed. But if they got less than 6 units of blood or didn't have any significant underlying disease, only 3% of people had a suture line failure. Well, that's pretty dramatic. So for the purposes of this study, we identified cirrhosis and HIV, because HIV was still a little bit new at the time. Diabetes, congestive failure, and renal failure in patients on steroids. I think they would be in everyone's high-risk category list. And certainly they are for destructive colon wounds. So we came up with this algorithm. If a patient has a full-thickness colon injury that's not destructive, to go ahead and primarily repair it. You can use single layer, 2 layers. I prefer 2 layers. Some of my colleagues do 1 layer. Doesn't matter. As long as you get a good repair, debride the edges, get a good suture line. Without strangulating the tissues, you're good to go. In a destructive wound, though, if the patients have associated comorbidities or if they get greater than 6 units of blood, they undergo diversion. Okay, sometimes we'll do a resection and anastomosis and then do a proximal diversion. Sometimes we'll just bring the end out. It just depends on the situation with the patient. However, if they don't have any underlying comorbidities or if they get less than 6 units of blood, they undergo resection and anastomosis. And this has become our management algorithm for patients with destructive colon wounds following penetrating injury. The group from LA also looked at colon suture lines, and they said they basically agreed. They didn't look at our particular criteria, but one of the few things that we've agreed on in the past, that they still say that there's room for ostomies in patients with high-risk injuries. Again, not particularly surprising, and it's always good when others sort of corroborate what you've said. We subsequently then looked at the durability of that particular algorithm. First, we stumbled upon the algorithm just by looking and seeing what we did at people. So then we thought, okay, once we implemented this treatment pathway, so we thought, okay, does it really work? So we looked at the next 56 patients who had destructive colon injuries. We found that the intra-abdominal abscess rate decreased, colon leak rates decreased, as did colon-related mortality. So we thought, okay, maybe we've stumbled onto something else here. So maybe that's the way to go. Right around that same time, the AAST sponsored a multi-institutional trial where they looked at management of penetrating colon wounds. And they had looked at 300 patients. That's a lot of patients. The problem is they came from 19 different centers. So already there's a potential for bias. And in regression analysis, they identified severe fecal contamination, transfusions, inappropriate antibiotic prophylaxis as independent predictors of complications. Well, it's not particularly surprising that if you have an abdomen full of stool, that those patients are going to have an abscess. I mean, that's sort of money in the bank. However, the abdomen full of stool does not mandate colostomy, and it is not associated with colon wound breakdown. It's associated with abscess, but not necessarily colon suture line failure. Okay, an important distinction. And this is what they found in this particular study. And they also said, in view of these findings, the reduced quality of life and the need for subsequent operation in colostomy patients, primary anastomosis should be considered in all such patients. So if you, again, exclude that, that's very similar to what Dr. Stewart said years ago. But one of the problems with this particular study is that they also concluded that the number of transfusions is an independent risk factor associated with complications, which came out in their logistic regression analysis, but they didn't really recommend the use of transfusions in order to help make the decision as to what you're going to do with that colon wound. And that's kind of a problem because it really should be part of the equation since we know that it's independently associated with adverse outcome. Okay? Lots of transfusions, you try to do as little as possible. They also had 19 different centers using 19 different management schemes, so it's very difficult to draw any significant conclusions from this particular trial because there was no real control for any sort of selection bias. So since we like to do things and then do them again and then do them again so that we can get as many papers out of this as possible, we actually went back and looked at, first we looked at the first 50 patients, then we looked at the next 100 patients to see if in fact this algorithm is durable in a single institution given the same knuckleheads over time who've been taking care of these patients. So we've all got the same mindset on how we're going to manage these patients. We all technically we've been doing this the same way the whole time, and we've all been pretty much sticking with the algorithm. So from that, I think you can determine, is this algorithm good or is it not? So what we found was that as long as we really stuck with the algorithm, we found significant decreases in abscesses, leaks sort of leveled off, and colon-related mortality also sort of leveled off. But the important thing is it wasn't getting any worse. So we think that this algorithm is in fact a pretty good thing. In this particular trial, you can see the numbers here, and transfusions were less, as they should be, less than 6 in the previous study and in the current study. What's interesting is that the weaponry in Memphis and the surrounding areas changed over time, as the destructive wounds have doubled. They went from 20% to 40% over 15 years or so, or 15 to 20 years or so. And that's indicative not just in Memphis, but it's, people don't walk around carrying little 25 pistols anymore. They walk around carrying AK-47s in order to shoot their fellow man. I don't get it, but nonetheless, that's what happened. So we've got many more destructive colon wounds to take care of now over time. We had 90% compliance with the algorithm. Now, you may say, well, you boneheads, you're the guys that came up with this algorithm. Why isn't it 100%? Well, it'll never be 100% because you're never going to know the true underlying comorbidities that these patients may have. Some of them come in already smoking a cigar. They're already intubated in the field, so they're not talking. Some of them aren't talking anyway, or if they're talking, it's not really what you would want to tell your mother. So you're never really going to find out exactly what their underlying, but transfusions, I can count. Unfortunately, that means I have to take a shoe off, but I can get to 6. Anyhow, so of the 102 patients who had destructive injuries, 92 of them followed the pathway, 69 had resection and anastomosis, had a 3% leak rate. For the 10 protocol violations, because we didn't follow the pathway, of those we had a 30% failure rate. So again, you don't have to be a statistician to realize that there's a difference between 3% and 30%. Personally, I'll take the 3%. So there's also been, over time, people have quibbled about, is it worse to be shot on the right side or on the left side? And as you know, the right colon, the stool, is typically more liquid, and the left side, it's a bit more solid. The colony counts tend to be a bit higher on the left side than on the right. There are some that say you should divert all left side. Who knows? Well, I'll tell you who knows. We know, and now you're going to know. So can you do resection and anastomosis in people who have destructive wounds on the left side? There is an anatomical distinction, not only from the contents of the colon itself, but also the blood supply is a bit different from the right or the left. Splenic flexure being sort of a watershed area that's can be a bit worrisome, but most reports only report right and left. They sort of leave the poor old transverse colon out of the picture. The group in Denver, just not too far from here, well, everything is all way out here. Everything's far away from me, but looked at 100 patients with penetrating wounds over 5 years. They didn't find any difference between right and left-sided injuries. But the group from Emory looked at 200 patients and found a big difference. In fact, they said that distal transverse colon and splenic flexure wounds you should really keep an eye on, and that perhaps you should change the way you manage based on this specific anatomic site of injury, because that's where most of their leaks were. Well, really, it's kind of difficult if you get into, and I don't really have time to get into that manuscript, but there was some potential selection bias that was involved in this particular thing. So we tried to look at this, looked at patients over a 13-year period, excluded early deaths and rectal injuries, and then of the 460 patients, a third of them had right colon injuries, 30% had transverse colon injuries, 14% had left colon injuries, and then a quarter had sigmoid injuries. And basically, if you break down the location, abscess rates were basically the same, leak rates were basically the same, and mortality was basically the same. So no matter how you did, if you look at colon-related, if you look at intra-abdominal abscess, you'll note that all these confidence intervals cross 1. Therefore, there were no statistical differences. Suture line failure, again, no statistical difference. And mortality, no statistical difference. So in a very large single institution series, there's no difference depending on which side you're shot in. So from that data, we concluded that injury location really didn't matter as far as impact, and that regardless of the location of the injury, all these patients can fit right into the algorithm. Well, what about blunt injuries? Blunt injuries are pretty uncommon, less than 1%. So we wondered, gee, I wonder if this algorithm is going to fit for blunt injuries too. This is sort of a one-stop shopping we were hoping for this algorithm. It's good because it's simple. You know, it's pretty simple. Simple things for simple minds. That's sort of the way I like it. Anyhow, we looked at all patients who had blunt colon injuries over a 13-year period, excluded those with early deaths, and excluded rectal injuries, and again looked at the same outcomes of suture line failure, abscess, and colon-related mortality. We defined destructive blunt colon injuries as large serosal tears that involved over 50% of the colon wall. Now, those of you that fix serosal tears, if you have a little serosal tear, it's no big deal, right? You throw a silk in it and you're done. But a big one, those can be problematic, and especially if you get that following a blunt injury, you know that there's been quite a blow to that particular colon, and that takes a reasonable amount of energy to cause a big serosal tear. It's pretty easy to see if you rip the mesentery in two and you lose the blood supply to the colon, that's a problem, or if a patient had a full thickness perforation. In this population, we had a similar, not 100% compliance, 150 patients, 140 that followed the pathway of those that underwent resection and anastomosis. Again, a 2% leak rate. For those that did not follow the algorithm, we had a leak rate of 12.5%. Not quite as dramatic as with the penetrating wounds, but again, pretty consistent. Notice a pattern developing here. So the algorithm seems to work pretty well, and this is just comparing with penetrating injuries. As you can see, a whole lot more abscesses with penetrating injuries. Again, not surprising because there's typically a whole lot more contamination. But suture line failure rates and mortality rates are very similar. So from that data, we concluded that the algorithm actually works pretty well for patients with blunt colon injuries. So what about this situation? Patients who have open abdomens, what do we do with them? You know, used to we put towel clips on these people, then we realized we were hurting them by giving them abdominal compartment syndrome. Now we treat patients in shock with this open abdomen. The group from Wake Forest looked at 22 patients that had an open abdomen. They had 11 that underwent delayed anastomosis. Okay, so patients who had their colon injury addressed, had their colon stapled off, came back to the operating room 24, 36, 48 hours later or so, and then hooked the colon back up together. They reported no leaks, and they said a delayed anastomosis is safe in selected patients. The truth is, half those patients died before they left the hospital. So I'm not sure if they had a bad problem or not. You know, so you have to read the whole paper. You can't just read the abstract, okay? A group from UAB looked at 56 patients who had open abdomens. 33 had resection with delayed anastomosis. They had a 12% leak rate, which seems about right. And they said that you should really be very careful. And a 12% leak rate, we think that's a little bit too high. Okay, 30 patients from Denver, 25 underwent delayed resection with delayed anastomosis. They had a 16% leak rate. And they concluded from a 16% leak rate that delayed anastomosis was safe in most patients who's managed with an open abdomen. So one group thought that 12% was too high. One group thought that 16% was okay. It's sort of interesting. It all depends on how we're looking at it, right? You know, 16, if you've got a leak rate of 16%, that means 84% did well. So it just depends on how lucky you feel. Personally, I don't like luck when taking care of patients. I prefer to try to minimize the amount of luck necessary in order to get the patient out of the hospital walking. So this sort of shows that huge leak rates depending on which institution and which study you happen to look at. So what about the algorithm? This algorithm is the greatest thing since sliced bread. I hope you all are picking up on this. You know, it's been, first we originally described it for penetrating destructive wounds, and now it works pretty well for blunt injuries. Does it work for patients with open abdomens? So again, we looked at 17 years worth of data, had the same outcomes that we looked at, the same definitions of destructive colon wounds that we've used in the past, had 150 patients with open abdomens, 32 patients had non-destructive injuries and they underwent primary repair, 117 had destructive injuries. There were 2 early deaths, so obviously we can't really tell much about them. So there were 42 patients who had delayed anastomosis and 72 had stage diversion. This just shows the breakdown of the patients, and there's really the only difference between delayed anastomosis and stage diversion, as you would expect, are the transfusion requirements in those patients. But if you compare those that failed their suture line with those that didn't, it's very difficult to pick those out. If you look at age, the percent of comorbidities, mechanism of injury, overall injury severity, and transfusion or shock, they look like the same patients. But compliance with the algorithm will separate them out. In fact, of the 23 patients that had algorithm compliance, compare that to the 20 patients with no algorithm compliance, you could tell that those that complied with the algorithm, by definition, were not quite as sick and not quite as injured as the other patients, right? Because they didn't get a whole bunch of blood transfusions. Not particularly surprising, but the interesting thing is that there was significantly decreased colon-related morbidity and no colon-related mortalities in those patients that underwent, that followed the algorithm, with significantly decrease in suture line failure. So from that data, we concluded that this algorithm works even for patients who have abbreviated laparotomy, and that's probably the way that we should go. So here's the algorithm again for those of you who were snoozing. I'll show it to you again. If a patient has a non-destructive colon wound, those patients should undergo primary repair. If they have a destructive colon wound, if they have significant comorbidities or get more than 6 units of blood, if they got an open abdomen, they get a stage diversion. If they got less than 6 units of blood or no comorbidities, get delayed anastomosis. So in summary, primary repair is a treatment of choice for non-destructive colon wounds. Resection and anastomosis is safe in selected patients. And if we adhere to a defined algorithm or clinical pathway, it can result in improved patient outcomes with specific attention to destructive colon wounds, patients with blunt colon injuries, and those that undergo abbreviated laparotomy. My favorite cartoon when talking about colons. Thank you very much, and I'll be happy to answer any questions.